This session is a case-based panel featuring audience polling, and the name of the session is Controversies and Considerations in Adjuvant Therapy for Advanced Endometrial Cancer. My name is Alex Olawaye from the University of Pittsburgh, and I'm joined today by my esteemed colleagues, Dr. Stephanie Ngay from Johns Hopkins University, Dr. Anuja Jingran from MD Anderson Cancer Center, and our esteemed patient advocate, Ms. Adrienne Moore from Georgia. As I said, I encourage everyone in the audience to participate by going to meetings.asco.org and selecting this session in the digital program. Here you will be able to view session details, participate in polling questions, submit questions to the panel, and take notes during the session. During the Q&A portion of this session, you can also go to the microphones here in the room to pose questions. In the digital program, you can also click on the CME/MOC button on the session program page to log your credit hours for each session as you go. Lastly, feedback is critical to the success and planning of this meeting, and we ask you to please take a moment and provide your thoughts on this session. You can do this during or after the session by clicking on the feedback link under the video player on the session program. Thank you. Learning objectives include variable presentations of advanced endometrial cancer, initial evaluation of advanced endometrial cancer patients, adjuvant therapy strategies for advanced endometrial cancer, and, of course, recent advances in endometrial cancer. Do you want to read the first question?
Sure.
First case.
All right. Hi, everyone. I'm Stephanie Gayard from Johns Hopkins. I'm going to read the first case, and then we'll open it up for discussion amongst the panel, and then also try to get some audience participation. So here's the history. She is a 64-year-old woman who had menopause at around the age of 50, presented with 1-year history of intermittent postmenopausal bleeding. Only medical history was significant for hypertension and reflux. And she had a BMI of 34 with a weight of 224 pounds. When she presented, she underwent a pelvic ultrasound, which showed a 9 by 5 centimeter uterus with an endometrial lining of 16 millimeters, and the ovaries were not visualized. She underwent a hysteroscopy in D&C and was found to have a grade 3 endometrial cancer. CT scan only showed the thickened endometrial lining, but otherwise normal findings. She underwent surgery with hysterectomy, BSO, lymph node dissection, and omentectomy. At the time, the pathology showed a 2-centimeter grade 3 endometrial cancer with depth of myometrial invasion was 57%. She had positive bilateral pelvic sentinel lymph nodes, and the omentum had microscopic metastases. Therefore, this was a stage 4B endometrial cancer. So first question is, did she present within a reasonable time period?
In my opinion, her presenting at such a late time in experiencing her postmenopausal bleeding would be the primary reason for her also being diagnosed with such a late stage of cancer. The question would be, what was preventing her from having access to being diagnosed earlier? Was it something that was, I don't want to say self-inflicted, was it something for her that was personal that kept her from seeking care earlier, or was it something that was being missed by her primary care providers, did she understand initially that what she was experiencing was something that was abnormal? Did she understand what menopause was, and that what she was supposed to be in a stage of her life when she was no longer bleeding? In her community, I'm not sure what race this person was, but this might have been something that was normal for what she was seeing. It could have been normal for her mother, for her grandmother, and for the people that she was speaking to, so she did not think that it was an issue that she should even bring up when she went to see her primary, who could have maybe recommended she see a specialist before that time.
Thank you, Ms. Moore. I actually can provide some of those answers. You're right. What leads to people not presenting on time are very multifaceted and multifactorial. But in her case, it was not access. She actually was somebody of means. She was a Caucasian lady. She was white. And she had not presented early because, in her opinion, the initial bleeding for several months, nearly a year, was only scanty. So she didn't think that was a problem because it wasn't, I think said something like she didn't need to use anything more than a panty liner, so that couldn't be a problem. Because every time a patient presents to me late, I'm very curious at finding out why did you think that you started bleeding again at 63 when you went through menopause at 51. And they'll say, well, my period came back, or the bleeding was very light, so I didn't think there was a problem, and that was the case here. But
then that would go to the point of why was she not educated enough to know, not that she was, I'm not speaking down on her knowledge level, but what type of education could have been done for her earlier to let her know that this should not happen. So you are now in menopause. There is in no circumstance that you ever see or have to use a panty liner or see any type of bleeding that is normal. If that ever happens, you need to seek care immediately. Maybe that was a conversation that could have and should have happened at the time when she discovered she was in active menopause.
Yeah, and I think that also we still in society at this point don't really talk about periods. This is true at a young age when girls are starting to go through it. This is not something that boys are really that aware of. But I think there's a push to make this non-taboo, and this could have been something where perhaps she was buying panty liners and her family members might have been like, why are you doing that? And there's something up with that. Maybe you should get that checked out, right? But it tends to be something that is kind of not discussed, put in the corner, and there's really no reason for it to be. This is just a normal part of being a human woman.
Right.
I think it's a public education issue. I think it's something, in my opinion, that should be talked about frequently on radio, on television. I occasionally get invited to some of these, women's societies and events to talk about women's cancers. I'm sure my colleagues said get invited to those too. And my favorite opening statement about this is, once you go through menopause, you have no right to bleed. Don't give explanation. You bleed, you see the doctor. Let them check you and tell you there's nothing. Don't explain it. I mean, things that you hear. I one time saw a woman who was a university professor of languages and had been bleeding for quite a while before she came to see me, and before she saw our doctor who referred her. And I asked her why it took her time to go see that doctor. And here was her explanation. She said the onset of the bleeding correlated to when she started taking yoga classes. So in her mind, yoga classes or the yoga maneuvers that she was making must have been responsible.
I actually have a quick question, and it's an interesting question. So we've changed our guidelines, to Pap smears and when you see your gynecologist, right? So it's now more infrequent when you get older. And I do think primary care physicians don't even ask that question because they think they're still seeing the gynecologist and don't know that. So do you think that has affected also the diagnosis of endometrial cancer? Because this is not a question that primary care physicians are asking, and you're not seeing the gynecologist as frequently because of the change in our recommendations on when you see a gynecologist or when you get Pap smears or any of that. So, I mean, the question is, has that affected? And I do think the other thing that has affected, which I'm seeing a lot of, and that's new, is COVID, right? I'm seeing a lot of late presentations of any cancer over the last 3 years because of COVID and the fear of coming to see physicians. But I do wonder if this is going to be a problem because we have changed the recommendations on how often you should have a pelvic exam and how often you should have Pap smears. And a lot of women, when they go through menopause, don't think they have to go see the gynecologist anymore, right?
Yeah, and I certainly remind people that even though the recommendation for the Pap smears is every 3 years, or at some point you can potentially discontinue, that doesn't actually go to the pelvic exam portion and seeing a gynecologist. That should continue, frankly, because there are other things that can happen, ovarian cancer and endometrial cancer and other benign conditions that are treated by gynecologists that should still be monitored for. So.
Yes, I think the change in the guideline for Pap smear, for those who are not familiar with the changes, now if someone has a Pap smear that is negative and they have HPV screening, which is actually the preferred ACS or NCI guideline now to accompany that, and the high-risk HPV screening is negative, it is considered safe for the person not to go back for 5 years for the follow-up screening. So Dr. Gingran was absolutely spot on, because the unfortunate situation is that the person then feels they don't need to see the gynecologist. And so for me, my advice, again, I think this should all reside in public health education, is that you need to see the gynecologist once a year, regardless of whether that visit requires Pap smear or does not. Remember, a lot of actually younger women and other people only see, they don't have primary care doctor, although they should. They only see gynecologists. So things like checking their cardiovascular health and if they are eligible for screening for conditions like breast cancer, the gynecologist does all of that. So there are other reasons to see a women's or gynecologist who can provide care and help to detect early onset of cancer.
I've been reading over your shoulder, so I see that a comment has come in about, not being specific about gender, and really this is true for all uterus owners, so it's certainly a point well taken, though it may be that we still fall into saying women. But certainly anyone who has a uterus, this is a concern for them. So.
Agreed.
Okay, so then the question comes to whether the initial investigations were adequate. And I'm going to actually send that to you, Alex, as frequently these patients will come to you first.
So this patient had a CT scan and, of course, endometrial biopsy, which led to the histological diagnosis. If the patient is bleeding and she's going to need an endometrial biopsy, which, in my opinion, should be everybody, especially if they are postmenopausal and they experience bleeding. So anybody with abnormal bleeding, even if they are premenopausal and the abnormal bleeding persists, and when I say persist, we're talking about a few weeks at most, the person should see a doctor and consider histological biopsy. The American Congress of OBGYN says that if a postmenopausal woman bleeds and she has an ultrasound, and the ultrasound shows that the lining is normal, that woman can be reassured without a biopsy. As you can imagine, none of us on this table would agree with that because endometrial biopsy is cheap. And so ultrasound to me is less important. Now, for women who present with either high-grade endometrial cancer after the diagnosis has been made, like, clear cell, serous endometrial cancer, carcinosarcoma, and even grade 3 endometrioid adenocarcinomas, they should have a CT scan. The reason is because these are endometrial cancer subtypes that tend to spread outside of the uterus quite quickly. And if that spread is detected prior to surgery, it will modify the way the physician approaches the initial treatment. So cross-sectional imaging, typically CT scan with contrast, is what she had, and that's adequate. PET-CT is done by some people, but that's an overkill. A PET-CT is not necessary. It's just too expensive for what you're looking for. Can we advance the slides? Thank you.
Okay, great. So just to kind of keep us on topic. So the next question was, well, what next after having had surgery? So I'll field this one, as this is a patient with stage 4B disease. And we know that chemotherapy is important in this situation. Our standard chemotherapy continues to be carboplatin and paclitaxel, typically for 6 cycles. You've heard in the last session about some differences depending on some of the molecular features of the cancer and maybe some novel therapies that may be coming along excuse me, in terms of maintenance therapy for certain subtypes as well. So this is an area of very active research, but certainly for someone who has advanced disease, we consider chemotherapy to be a very important part of the treatment of this disease at this point in time. And then I'll let Dr. Vingren talk about radiotherapy.
So I agree. This is a stage 4 patient, so she actually has a high risk for distant metastases. So the role of radiation therapy, which by multiple randomized trials is really to improve local control, isn't probably beneficial in this area because her risk for distant metastases is much higher, right? I would consider, since it's grade 3, maybe looking at her after 6 courses of chemotherapy and seeing if I should add radiation, but she had really... she had a big tumor, right? But she had only 57% invasion. So I think I would probably just watch and see if she recurs. And when she recurs, then maybe treat her if it's local. I mean, that's actually what the data shows, is that the reason why radiation therapy did not improve survival is patients can be salvaged when they recur locally with radiation therapy, right? So in this case, I think the risk of distant metastases is so much higher that the role of chemotherapy or systemic therapy in general is really more important. So I do have a question, though. I mean, if you saw more, and granted, it's a grade 3, right? So you're not looking quite at P53s, but some grade 3s are positive for P53s. Or is there any other molecular things you would look at for this patient? Mismatched genes that would change your poly? Anything else you would think about?
Yeah, so we would generally get that kind of testing, the molecular testing, at the time of diagnosis. Our pathologist will reflex test for the MMR proteins by IHC. We'll also get P53, estrogen receptor, progesterone receptor, and then sequencing for POL-E, as well as sort of a panel of others that are perhaps more investigational at this point in time. Honestly, having the benefit of being at a large academic center where our focus is on clinical trials, what I would be thinking about is whether this patient is eligible for a clinical trial and whether that might be the best option for her. In this particular circumstance, stage 4B, she would be eligible for GY018, which is a study of carboplatin and paclitaxel with or without pembrolizumab. And it is enrolling patients who have either MMR proficient or MMR deficient disease, because we don't yet know whether the addition of an anti-PD-1 therapy is beneficial at the time of initial chemotherapy for patients with MMR deficient disease. We clearly have seen a benefit. The last session we talked about the very impressive data from the Garnett study on dostarlimab for recurrent disease, in which it's an approved indication, as is pembrolizumab. But we haven't yet proven that it's necessary to add it to chemotherapy. Now, there are some hints from some smaller clinical trials that look really promising, but until we do the big study, we don't actually know. Now, the other thing, so let's say we don't have clinical trials available, and of course we're going to hear about potentially alternatives to chemotherapy when LEAP-001 comes out. We'll find out whether we can bypass chemotherapy altogether, but at the moment, carboplatin and paclitaxel are still the standard of care. Per GOG 86P, there may be a little bit of an advantage to adding bevacizumab for some of these patients, and then the subset looking at the P53 and how that influences benefit is also very interesting data, but is not really proven. It wasn't originally designed to test that question. So I think it's still somewhat preliminary. But I think that certainly this patient, we could consider adding bevacizumab, given that she does have advanced disease.
I just have a thought on that. You spoke a lot about just that this particular patient having access to clinical trials, but when it just brings about a thought to me that when should the patient be approached about their potential eligibility? At what visit does that happen? Because I think a lot of patients are being missed, especially ones that are not in going to hospitals that are big teaching hospitals or in rural areas. Especially women of color are rarely approached about participating in clinical trials, which really has a huge effect on just our knowledge base about what we could actually do to help advance the science. And we want to be involved in these things. And I know, speaking from my personal experience, that could have been something that was approached, that my gynecologist approached me with once I was diagnosed. Maybe I would not have considered it, but to know that there was a potential for me to be a part of one would have been good to know. So that's always something to consider too. I love hearing about all the advances that are happening in endometrial cancer, but I really would like to know that these things are being knowledge about them is being afforded to every woman with endometrial cancer who could potentially qualify for a clinical trial.
I actually have a question for you, and I'm sorry. So it's a really good question, is when should you approach a patient for clinical trials? And as a patient, a previous patient, when is the right time, right? It feels is it when you get first diagnosed? Or, I mean, it's a good question. And so when do you feel like it's the right time? Because I feel like sometimes patients are overwhelmed when they get the initial diagnosis, and then we have 1,000 trials, and that's really when we want to present it, and then they get even more overwhelmed, and I get pushback, right? So the question is, when do you feel is the right time?
Yes. So I had not an extensive time period, but I had at least a few weeks before I was diagnosed, scheduled for surgery, and then scheduled for a port. correct? So by that time, I had the chance to reconcile that I had this diagnosis, work through those emotions, make the appropriate arrangements I needed to make, considering what my treatment was going to be. And then there was a lull in time between maybe the time I was diagnosed to when I had surgery, and then a port place. And by the time, I believe by the time you're ready for your port placement, there is a period of acceptance that has already happened, where you have moved out of the denial portion, because you think even when you're first diagnosed that they may, during surgery, they could eradicate the cancer. Oh, we got it all. You won't need to have any other. You won't need to have any other treatments. But once you know that you are going to be scheduled for more treatments, and you have moved to the point of accepting that this is going to be the course of action that's going to be taken for you, then that would, Dr. Nusha, be a good time for approach.
Can I just say quickly that, there are two problems that surround the issue of participation in clinical trials. And so the one that you have addressed very eloquently, Adrian, is, in my opinion, the bigger one. It's like, does the patient or do the patients have access to clinical trials? And are they being presented with the clinical trials? But I can tell you from the NCI point of view, from the NIH point of view, actually it's a Congress mandate that clinical trials be offered in a proportionate way. What NIH wants to see on a grant applying for a clinical trial is that you are going to enroll proportionally from all the diverse population of people affected by the condition you're going to be spending their money for. And if sometimes you're not able to convince them that there will be proportionate accrual into that trial, it could be a major problem for you. Now, overall, clinical trial participation in the United States, I can tell you right now, is extremely dismal. The data that I'm aware of actually shows that, generally speaking, we enroll somewhere around 5% of the population of people that are actually eligible for trials are enrolled in clinical trials. So it's like a very poor performance all around. But I'll say one thing in answering one of your questions, Adrian. To participate in clinical trials is something that requires the patient to trust that her best interest, is at the heart of what is being discussed with her and what is being offered to her. And I know that the best interest of the patient is in the heart of all my colleagues offering clinical trial, but the patient needs to know or sort of reconcile with that fact, because there is a notion out there that clinical trials, people think about the guinea pig phenomenon. You're just going to put me on this trial so that I can be used as a guinea pig. I explain to patients that the clinical trials actually is a reflection of how much the doctors who take care of patients affected by cancer, how much they care, because almost all of them are based on trying to improve on what is currently available. And when they get to hear that, it helps a lot of them to decide for clinical trial. And, the question that you asked specifically about when, I would say, so initially when a patient like this came to see me and we talked about surgery and all that, just understand that surgery was necessary for us to get all the information that we need in order to know which way our treatment is going to go. So it wasn't a good time to offer, unless you're doing a surgical trial, it wasn't a good time to discuss clinical trial anyway, because we don't have enough information about the cancer. So the surgery needs to take place first and all the information gathered before we discuss research or treatment approach.
Yeah, but I would say at the same time that you can put the nugget of the idea in the patient and present it to them in the idea of, okay, we're going to have surgery. Following surgery, depending on what we find, standard treatment might involve chemotherapy, might involve maintenance therapy. That sets the stage for sort of preparing the patient for how long someone might need to be on treatment, and that a clinical trial may be an option. And so, to a question that has been submitted is, would it be reasonable to talk to patients by phone afterwards, later on, about a clinical trial so that they're not overwhelmed at the time of the visit? I think that's very reasonable, and frequently the way that we'll approach it is I'll say that we have, we have some options in terms of treatments. There's standard of care. There are clinical trials. We talk about the logistics of what it means to be on a clinical trial before really diving into the specific details. And I have a research nurse follow up with the patient, and we may set up additional calls or visits. Now with telemedicine, at least within a state, it is a little bit easier to have those follow-up kind of telemedicine visits so that patients can have their families with them, and we can have more detailed discussion about clinical trials. But I think it is important to set the stage early. And then on a separate note about the access to trials, and while there is certainly a mandate from the NCI to enroll patients that kind of show the breadth of the disease and the various different factors that are involved, we need to decentralize our trials so that they are not at large academic centers, that they are more available in the community, and certainly that's one of the goals of the NCORE, as well as some other missions. But are there ways that we can bring the trials to the patients rather than forcing the patients to come to us? There are certainly some things, brand new drugs, where we really don't understand the side effect profile, et cetera, that need to be done at specialized centers. But some of these where, G018 is a perfect example. Everyone has experience with anti-PD-1 agents. None of those things are going to be a surprise, and so getting those trials closer to the patients so that that reduces the barriers for them to participate is really important.
Yeah, and I want. Oh, sorry.
A question just came up, and I'll let you follow up with your comment. It's actually a comment. We need to speak clinical trials participation barriers have to be acknowledged. There's something the person wrote. Is that delays? Okay. Delays to get centers, path review, too strict criteria for inclusion. And we agree with all of. I think that's what Dr. Gaillard just spoke to. Adrian, please go ahead with your comment.
Yes, I was just going to say that, I am not an oncologist. I am an endometrial cancer survivor, and as a patient advocate and someone who has experienced this disease firsthand, who's experienced a delay in care because of my symptoms not being acknowledged, part of my, I don't want to call it my job, but part of my duties are to help destigmatize being a part of clinical trials. We need to make those a normal part of conversations as well when it comes to advancing care in endometrial cancer.
Adrian, I actually have the next question.
Well, I was going to ask that because we're talking about all these clinical trials, right? So one, I think, yes, access is really important, but the next question is really the most important thing is family support and psychological support. And really love to hear your thoughts on that, because I have a patient who's actually refused chemotherapy and has recurred with endometrial cancer and actually still refuses chemotherapy. But you know what? Her family's been very supportive and brings her, she only wanted radiation therapy, so we're radiating her, but her family, so the question is, how important is that, and what are your thoughts about that, and what does a patient really need?
Well, I think first we all want to consider the patient's, what the patient wants. Ultimately is their decision about the care that they receive. They can deny care because that is absolutely their right. And again, her support structure is there to support her also in what she wants. But I think a patient having the knowledge that there are other persons out there like herself who have the same diagnosis as herself and has received treatments in regards to what you are ordering, Dr. Nugent or Dr. Alex, that to understand that this is something that could be helpful to them. And it also, that might call for them to have some psychological care. We might need to build in those kind of support structures into standard of care practices so that they'll be able to talk to, like once you are diagnosed and you understand that you have to go through treatment, should some psychological therapy be part of your treatment plan to prepare you for what you need to go through to get through treatment, to and through treatment? So that's what I would say.
Thank you. I just want to remind the audience that please feel free to step up to the microphones because this is supposed to be bidirectional. We welcome comments and questions from the audience. I know you have opinions, so don't feel shy to bring those opinions out.
There you go.
So speaking of that psychological care, it's one of the things I struggle the most with my patients. You know, every cancer patient and their family experiences some level of anxiety, depression. I mean, it is inherent in the disease, but finding the right ways to help support patients through that. We have things like PsychOnc, which is, you know, psychologists that are, and psychiatrists that are specialized in oncology, clinical care managers, therapists, things like that, but oftentimes they get a lot of pushback, like, I'm fine, I'm okay, I don't want to see somebody else. And obviously it's not a one-size-fit-all, but would love your thoughts on kind of best ways to approach that and kind of the spectrum of help that we can offer.
Thank you, Dr. Kaufman. Anybody else?
So I would say along those lines, it's absolutely true that there's lots of different possible ways of approaching this. And one of the things that we've done at our center is to have a woman-to-woman program with women who have gone through treatment and are survivors of their type of cancer. And we try to pair them. They go through a training for, how to help patients who are then now going through it. And that gives that very personal non-medical kind of support and connection that our women find really helpful. Some of them don't choose to take that, but we try to offer a number of different services to allow women to choose what they think is going to be most helpful to them.
Thank you, Dr. Gaylord. That actually, I think, is so important. In my program at the University of Pittsburgh, we actually used to have two psychologists that are part of the division of the gynecologic oncology over there, and we lost them. For those who don't know, it's very difficult to hire them. And so the hospital tried to replace them over the last 2.5, 3 years, we have not been able to. We do call psychologists who are part of the general university psychology group. The best thing they can do in most cases is to schedule an appointment with the patient to go see them. But having a psychologist as an integral part of the cancer, care team, I think, Adrian, is absolutely important. There's a comment or question coming? Yes, please.
Yes, hi, my name is Natalie Hawk. And I did have a question to the point of the psychologist or psychiatrist involvement. What about a spiritual counselor? I know that can have a role, but usually their role is in an acute situation when someone's hospitalized, but there's also a role, particularly for that interpersonal relationship, when you're not necessarily wanting to have a clinical type of concern. But so I was just wondering if that's something that's been considered or found to be beneficial in your practices or in your experience.
Yes.
Yeah, I think that's really all. So it's interesting. There's a lot of ways to get around that, right? So I think, some of the smaller hospitals use navigators, right? And the navigator becomes that patient's key person to get them through that journey. And I've seen the smaller hospitals really do well with navigators because the navigator will connect them to patients or connect them to spiritual leaders or, social work. And so, that's another way to get around it. But I do think spiritual things are, spiritual connection is really important. A lot of my patients get it from their community. So, we don't have to offer it at the hospital, but I know a lot of my patients 100% get it from their community. In fact, that's probably the way the community helps them the most, right? But it is, there are a lot of patients that are isolated and are somewhere else getting their treatments and they may not get it. So that's a good point.
Yeah, and I would say, too, that when we talk about community, we are talking about women who find each other and find a common ground in the things that they want to see in support through treatment. And one of the programs that I'm involved in through ICANA and through the sister study run by Dr. Kimmy Dole is an intervention, a social support intervention where we don't particularly offer spiritual support, but offering social support includes all of those things. We talk about things that are emotionally connected to having treatment. We talk about things that are spiritually connected to going through treatment. So really, when it comes to offering spiritual support, I would say that it's important for the person and the patient to find their community wherever that community might be. And that could be an online community, that could be an in-person support group community in the church, or even in their local hospital.
Well said. I think we should just go to the second case so that we can be able to do justice to it as much as we did to the first one. So, 56-year-old lady who presented with irregular vaginal bleeding. She indicated she never went through menopause. Medical history was significant for idiopathic thrombocytopenic purpura, hypertension, type 2 diabetes mellitus, and she weighed 225 pounds with a BMI of 43. Investigations done included ultrasound that showed a 14 by 8 centimeter uterus with multiple fibroids, and endometrial lining could not be assessed because of the distortion due to the fibroids. She had a hysteroscopy, dilatation, and curettage that resulted in the diagnosis of serous endometrial adenocarcinoma. And she had a CT scan of her torso, and there was a soft tissue mass in the endometrium and enlarged left parietic lymph nodes. She had surgery, which was just standard surgery, including hysterectomy, removal of the ovaries and lymph nodes, and enlarged lymph nodes particularly were resected. And the final pathology report showed a 2-centimeter papillary serous endometrial cancer with a depth of invasion of 85%, and all the resected pelvic lymph nodes were negative, but all of the 10 lymph nodes taken out of the parietic chain were positive for metastasis. Next slide, please. It went back.
Yeah. Go forward again.
Next slide. Okay. So the first question is, do we think she presented within a reasonable time? And I can quickly take that on because for those who are not familiar with the statistics, roughly about 81% of American women go through menopause around about age 51. And the upper border of the age range where people go through menopause is roughly about 54, although 55 years is written in the books, but most people are menopausal before that age. The one very important cue that physicians can take is towards menopause, what we typically call climacteric. The periods should be getting more scanty, more spaced out until they stop. If in that period they are getting heavier and disorganized, I would be concerned and would want to check the endometrial lining for that 52, 53-year-old woman. Because in this case, as you can see, she clearly, at some point, began to experience abnormal bleeding, but because she had not had a defined menopause, she thought everything was okay until eventually she saw a doctor who decided to do a sampling of her endometrium.
Just a couple of things that I do want the audience to notice, that both of our patients were obese, right? So I think that's a really relevant thing. Obesity is, as I think all of our audience knows, the number one cause of endometrial cancer. It's also something that we can prevent, and we can use as treatment, therapeutic to prevent recurrences, right, to have them start losing weight afterwards. But I think that is important for us to notice that both patients were obese, which is really an important, relevant point.
Yeah, you actually read one of the comments that had just come up.
No.
So that was well timed. But yes, absolutely. I mean, it is alarming, the increase in endometrial cancer rates, and something that we really should be able to impact on. And that is something that needs to be talked about more. The next question was about sort of what next after surgery. So this is, again, a situation where we would strongly favor doing chemotherapy. These are high-grade but high-risk subtypes, the high-grade serous. We put a few others in this category as well, carcinosarcomas, clear cells. And so in this case, adjuvant therapy certainly plays a role, adjuvant chemotherapy in particular. Again, standard of care is carboplatin and paclitaxel, but with the serous histologies here, it's especially important to get the molecular testing, and in particular HER2 testing, since there's data that shows that adding trastuzumab to chemotherapy for patients who have cancers with high levels of HER2 or HER2 amplification benefit from the addition of the trastuzumab. And in fact, there's going to be a NRG study opening up later this year, which is GY026, which is going to be looking at the role of adding on anti-HER2 therapy.
So, Ms.
Can I say something real quick? So this is where I think there's a little bit of a difference in treatment. And I'm going to be very controversial, and I would love to see what people say, but this is really a little bit of a difference in treatment, United States versus Europe. And I do think it's debatable, and it comes from two different studies, right? Protect 3 and GOG 258. And I do think these patients are treated differently in the two different continents. And I will be honest, in our institution with so many positive nodes, even though her risk for distant metastases is high, and what 258 did show was that patients who got chemotherapy and radiation therapy had a little bit higher incidence of distant metastases. Local recurrence is pretty high because she had positive nodes, and so many of them, right? So there's multiple ways to treat this patient, and I do think radiation therapy plays a really important role in this patient. And the question is when to do it. And again, this is where the two continents come in. In Europe, this patient would be treated with concurrent chemotherapy and radiation, followed by more chemotherapy. I do think a lot of people with so many positive nodes in the United States would definitely give this patient 6 courses of chemotherapy or do sandwich chemotherapy. So do 3 courses, do radiation, and then do 3 more courses because the local recurrence rate is so high in the periodics. So I do think radiation does play a role in this, depending on how you want to give it.
I thank you, Dr. Gingren. It's a very controversial area, and I think if you talk to people from different, especially academic centers, big institutions, their opinions vastly differ about what radiotherapy adds to this group with advanced endometrial cancer. For instance, our understanding of those big trials the European trial showed that there was progression-free survival advantage of doing adding radiotherapy to chemotherapy in the POTEC 3, but overall survival was not different. And the study in the US, the GOG 258, actually, the group that had radiation and the group that had chemo alone, they matched each other. They were mirror images for progression-free survival and overall survival. So it's going to remain controversial until we have definitive findings from studies that show that that addition is good, because it's not without added toxicity. That is the problem. But I have a question that came up here. How do each of your institutions do molecular profiling, polymerase epsilon E testing, P53 assessment, and microsatellite status assessment for endometrial cancer patients? I can answer for the University of Pittsburgh. At this point, and luckily my colleague Dr. Kaufman is here as well, those of us treating endometrial cancer, we like to have all these assessments done on everybody. But our pathologists are not doing them as a reflex yet. You have to ask for it, and that's how it is right now. Hopefully some national guideline is going to come out that actually makes it part of standard that would help us make them do it consistently.
Yeah, at Anderson, we do P53 and mismatch genes on everybody. I think there's still a big debate on poly because of how to diagnose it and all of that. So our pathologists are really fighting against that, and it's also expensive. I do think poly is going to be probably really relevant, but it's going to be how we really diagnose it to decide if it's going to be relevant.
Yeah, so similar at Hopkins, and I would say the question with POLE is really going to end up being, does it help us in terms of potentially de-escalating care? And there's a clinical trial that is coming soon that is going to be asking that question. So I think it's going to be important to do that up front, given that we know that those patients frequently do very well even in the absence of adjuvant therapy.
Stephanie, this question is actually specifically for you. Has the woman-to-woman program at Hopkins replaced support groups, or is it in addition to support groups?
Yeah, it hasn't replaced support groups. Those certainly have a role, but it is in addition to, and something that it seems to me it's not uncommon for women, at least initially, not necessarily wanting to be part of a support group. They like the idea, but they're a little concerned about hearing from patients who may be at different phases of their cancer course. But they really do like the women-to-woman program because it is typically tried to be very matched with someone who has gone through very similar experience.
Yes, Dr. Kaufman?
Follow up on the molecular testing. I'd be interested to know, do you send these folks for genetic testing given the serous histology here?
Are you like next generation?
Oh, no. Genetic germline testing for BRCA.
So if in our program, as you know very well, all of them have the Lynch-associated proteins assessed in their tumors. And if they have a deficiency of one or more of those proteins and it's not due to hypermethylation, which is tested for, yes, we do send them to genetic counselors.
I'm asking about the serous histology, which tend not to be mismatch repair deficient. And obviously there is some overlap, but the serous histology, they're generally going to be the copy number high P53 mutated folks. You send them for BRCA testing or panel testing for the HRD side of things. Germline.
So not generally, unless there's something else in the history that is sort of pointing us in that direction. Or if we are getting NGS testing because of advanced disease, trying to identify clinical trials or something like that, and it identifies then something that requires genetic counseling.
In the last few minutes, we have some questions that we're hoping that the audience can participate in. Can we go to those questions, please? So first one is, does obesity have an impact on high-grade endometrial cancer? And the answer, of course, I think we gave that one away earlier. Okay, next one, please.
So it's interesting because we often think about obesity as being high levels of estrogen, and so then with the estrogen responsive cancers, which are more likely to be the low grade and everything else, it increases the risk for all of them.
Do you want to read the next one?
Sure. Does genetics play a role in the development of endometrial cancer?
Slide, please.
So I'm not sure if they're showing us what the audience is.
Yes, are we able to see?
Oh.
Yeah.
Why don't we raise our hands?
Why don't we raise hands?
Yeah.
Yes.
All right. Does genetics play a role in development of endometrial cancer? Votes for yes.
Okay.
Votes for no.
Clever audience. Slide, please.
No nor irrelevant. Yes.
Yes. Although that we know right now, it's only a small proportion of endometrial cancer patients that the origin of their cancer is based on a genetic mutation background, less than 5%. But certainly, they are worth going after because they're a special group that you can help them and their family.
And there's a small proportion associated with BRCA, but it is really very small.
Small, yeah. And that's where serous endometrial cancer may be relevant.
Right.
Next question.
Are there racial differences in the distribution of endometrial cancer? Votes for yes.
Yes.
Votes for no. No nor irrelevant.
So it's really interesting that we were just actually looking at the data, and there's about 12% incidence in African Americans, which is the highest incidence. So it is, and the sad part is they're probably the ones that we don't put on trials and the ones who are not getting access to care and who are presenting with the latest stages. So I think that's such a big, in endometrial cancer, this is a huge divide.
It is a huge divide. And I think we had a question earlier that was related to obesity, but we think about that a lot of black women live in food deserts and have a tendency to have diets that attribute to obesity. They are making up a huge percent of that factor. So that is something to think about in consideration to this racial difference. How do we teach African American women to eat better for their survival?
Great, thank you. Next question, please.
And while it's coming up, I was just going to make a point that this morning in the oral session, I presented some of the data, and not only is there a rising incidence across all women, but in black women, but also the mortality rate is increasing in that group more so than in other groups. So this is really something that we urgently need to change.
And that is because we are presenting at later stages because we don't have the proper access to care, the proper education. We don't know about prevention such as changing in our diets. And oftentimes we don't know our history, our family histories of cancer as well. So all those things are factors. And that means we really need to start from scratch in teaching them about and talking to our women, black women, people in the black community about endometrial cancer and about our risk for endometrial cancer.
And in the last minute, does adjuvant therapy has been answered? The audience is so...
So adjuvant therapy is certainly very important in the treatment of advanced endometrial cancer. And I will just reiterate that clinical trials are the only way we learn about advances. And unfortunately, at this point in time, only about 5% of patients with GYN malignancies go on to clinical trials. And we would advance things a lot faster if we enrolled more patients. We need to make them more accessible, decentralize them, and make true advances in this disease.
Please go ahead with your question.
Yeah, so this is Gina Westhoff from Portland, Oregon. In light of some of the racial prevalence of these cancers in Black women, and what we learned yesterday about genetic rates of BRCA being higher in Black women. What do you guys think about universal germline testing for endometrial cancer patients to kind of help pick up hereditary cancer syndromes?
I think that would be very difficult to implement, and based on the percentage of endometrial cancer patients that actually are that originate from genetic abnormality, I think it will be cost ineffective. If you're talking about ovary cancer patients, yes, 100%.
I'm kind of thinking about the patients that we may see with endometrial cancer, and not about picking up the actual germline mutations due to endometrial cancer, but those that may be, just other mutations that they may be at risk for because they don't know their family history. And the cost of genetic testing has come down so significantly. There are more universal testing programs. The gentleman from Ontario presented one from his, they did only have a 2.4% positive mutation identification in that cohort. But of those mutations, I think it was like half or a high number of them were in patients that wouldn't have met testing criteria based on the NCCN guidelines. And so I've always felt like with the cost of testing going down and there being a fair number of mutations that we're not identifying based on either lack of family history or secondly, mutations that are not being seen based on just not matching up to the NCCN guidelines, what's the downside other than, I guess, relative cost and access?
Yeah, so I certainly think it'll be interesting, and I think we will eventually get to a point where we are doing this kind of testing for all cancers. And we're going to be learning about more about what the hereditary predispositions are, as well as the specific mutations within the tumor. And then, of course, that has downstream effects because then we can hopefully help to prevent cancers in those patients' family members as well as their children. And so hopefully that will be a way to do it. But the cost issue is still a big one. We know about the toxic effects of the financial toxicity of care, and that is a contribution, although a smaller and smaller one these days, luckily.
No, I think the end thing that we need to know is that endometrial cancer is moving more to a more personalized treatment. I think molecular testing is going to be important, which includes, I think, genetic testing as well. And I don't think we're going to be treating everybody the same anymore. And I think that's where we're heading. And that's what all these trials are heading to.
Yes, thank you.
But to give you a flavor of the type of problem that we might encounter trying to do that, right now, in my institution, and Dr. Kaufman can be a witness to this, patients that have P53 signature, because now the fallopian tubes for women that have benign hysterectomy type of surgery, they are processing their tubes and they're finding all these abnormalities that may suggest that they are at risk for being somebody that has a genetic abnormality. I have not succeeded in getting, when I order the test on them, I want to know whether they have BRCA1 or 2 mutation or any of the HR-related genes, and I get pushback 100% of the time. The payers will just not pay for it. I think our time is up. Thank you so much.
Thank you for staying.
Thank you. Really appreciate it.